28 bone lesions. PET were the same, so when you were able to see one in the PET from the PET CT, you were also able to see the PET MRI and vice versa. In low-dose CT, they were not able to have a corresponding lesion in CT. In two cases, in MRI, they found all of the lesions. So MRI offers better delineation than low-dose CT as before. And this is just one example, again, where there is a lesion in the bone that was not visible in CT, but you could see in MRI, T1, T2, and also diffusion was also visible. So again, that points to an advantage of PET MRI versus PET CT to see lesions if they don't really are 100% interpretable in PET. And that is a very, very important aspect of PET MRI, of the MRI component of PET imaging, because there are a lot of tumors, for example here, patients with a biochemical recurrence, and they got PSMA PET CT, and you can see that if you have a very low PSA values, a lot of recurrent tumor is missed, and that is on a per patient basis. It's not on a per lesion basis, on a per patient basis. And the urologists tell us they are very interested in everything that is below 0.5 PSA. They get less and less interested the higher it is. And there you can see that more than 50% of patients with a biochemical recurrent cancer, you were not able to see a lesion that takes off PSMA. So CT, or the complementary morphoanatomical imaging device, is really important in these patients. So high number of recurrent tumors do not show adequate tracer uptake. And that is not even so on a per patient basis, but even on a per lesion basis. This is just one example from our department, where the patient had bone metastasis of a prostate carcinoma. So that was validated by the pathologist. But if you then were looking into the prostate, you have in the MRI, you have a lesion that's very suggestive of prostate carcinoma, but you weren't able to see any PSMA uptake, even though metastasis showed PSMA uptake. So that is what we quite frequently occurs, that not all of the lesions have a proper PSMA uptake. And that is tumor manifestations without PSMA uptake may be visible in MRI. So I also want to show you some example what the value is to add additional sequences to imaging, for example, diffusion and high-resolution images in different image planes. That is one patient who had elevated PSA values years after primary treatment, and that is actually the biggest group that we get at the PET MRI is a biochemical recurrent cancer. The question, of course, is are there visible metastasis or local recurrence responsible for the PSA elevation? And we did MRI with additional diffusion imaging, and you can see here that it's a lesion that hasn't got uptake on PSMA, but you can clearly see in T1 that there is a lesion there, and if you look at diffusion, you can see that it's a diffusion-restricted lesion that is was later confirmed to be a metastasis of prostate carcinoma. The same patient also had a pararectal metastasis in a lymph node. Here that had uptake in PSMA, but certainly you would have missed the bone metastasis without MRI. Okay, a different patient also, same setup, elevated PSA years after initial treatment, also with a metastasis. We have done additional high-resolution imaging in the sagittal plane, and if you look very, very carefully, you can see that there is In the last segment of the sacrum, you were able to see in T1 imaging the hypointensive lesion there, and you were also able to see a correlate in diffusion imaging. So we are of the opinion and that additional high-resolution imaging is necessary, and that comes back to what I've said before. To really have good protocols is very essential. So we think, and I think, it's not good enough to just have whole body MRI sequences, but you also have to make up your mind what additional localized sequences you want to have in order to make fuller use of MRI as part of your PET MRI. So that is something I think is very important, but also very difficult, how you design your protocols, in order to have whole body coverage, but also to make use of MRI information where you most likely will need it. For example, prostacarcinoma, that's the bone in the pelvic and the pelvic area and in the vertebral column. Okay, now I just want to point you towards imaging that is important for imaging and therapy. We are lucky as nuclear medicine physicians that we can have the whole range imaging, but also treat our patients with radioactive substances. And in the field of bone, very important is the new treatment of radium-223 versus treatment options that target PSMA. And this one is just one example that shows you why imaging is important, and to choose which of the two treatment options to choose. And this is just one two patients when we started with Xofigo, radium-223 therapy. This is a 65-year-old patient that had castration-resistant symptomatic bone metastasis and also no visceral metastasis, and that is all you need to know in order to have an indication for radium-223. And of course, you have bone scintigraphy, and because of the same mechanism, bone scintigraphy should give you uptake. And if you have that, then the leaflet in the packaging basically tells you to go ahead. And but if you then do PSMA imaging that gives you more indication of where the tumor is, you can see here that if you have a match, it's relatively well matched. You see a lot of uptake in the bone scan, also where you have PSMA tumor in the bone marrow mainly, but you see that the bone is reacting to that. So it's a very good match. So without PSMA PET, there was an indication given, and we have seen a lot of concordance with bone scintigraphy. So we basically went on to do radio-223 therapy as told by the urologist. But then I think it was the second patient, just at the beginning, where you were just being accustomed to what the indications are, what you have to look into, what to do, and then we had this patient. That was known. He was sent to us. He had a lot of metastasis, and they had a higher bone mineral turnover, also on scintigraphy. He had pain, so everything was okay according to the leaflet. Go ahead. But if you look at the PSMA, you have a completely different story to tell, because you have a very, very extensive tumor manifestations in the bone marrow of the spine. This one was irradiated before, so you don't have uptake here. So if you would then just give Xofigo therapy, you would have missed most of the tumor. And at that time, we contacted our colleagues in Heidelberg, who were the first inventors of PSMA therapy. At that time, we started, I think it was in the middle of 2014, this case. So we sent the patient to treatment in Heidelberg. So without PSMA PET, indication for radiotherapy, for radium-223 therapy was given, but with PSMA PET, we had a discrepancy between bone marrow turnover and the bone marrow, so that was something we have done. So I think that is a very important aspect of PSMA PET. but also a very difficult one. Of course, what we want to do it with PET MRI, that was still PET-CT. MRI may be better to show bone marrow lesions, but that still needs to be evaluated. But very important is to really look of what of the therapy options you would have to you are going for. Just one image is not bone, but just tells you you can have staging with whole body PET MRI with PSMA like we've done. In this case, it's not bone metastasis shown, but lymph node metastasis here, and these are imaging because lutetium-177 also has emits gamma radiation, so you can really see the effect of giving PSMA therapy. Yeah, this one after the first cycle, after the second cycle, it's almost disappeared. And we normally give 4 cycles, that's the standard, and it's working very well. Now, shorter, I promise, primary bone tumors. Osteosarcoma, Ewing sarcoma are the most prevalent in Münster. Ewing sarcoma, we are just starting to get our colleagues interested in using PET MRI because, as you know, the problem is always also lung imaging, and PET MRI is less well adjusted to lung imaging than CT. So still PET-CT is number 1 in Münster, but PET MRI is coming. So if you look at this one, at the tumor entities, established roles of imaging is X-ray to have the diagnosis, not MRI, but X-ray. The X-ray, the MRI is more a secondary evaluation that gives you more information about soft tissue component, also infiltration of structures is important, and gives you better skip lesions in bone marrow. Bone scintigraphy is also used to give you some indication of bone metastasis. Also, I put it also in this list, FDG PET is also sort of established, but it depends on where you are and where our patients are treated. In Germany, reimbursement situation is worse than in France, so FDG PET-CT is not available everywhere, but of course Ewing sarcoma and osteosarcomas are better treated in larger centers and they normally have access. So in order to estimate the potential role of PET MRI, you have to look at the role of PET and the role of PET MRI, of MRI, because there are not really data available for PET MRI yet, because it's a relatively rare disease. PET MRI is relatively new, so you have to look into, I think, the individual things here. Just the value of PET-CT, it's one thing. They looked into pediatric bone sarcomas and looked at the diagnostic performance of FDG PET-CT versus conventional imaging setup for initial staging and follow-up. Just give you the brief results. For osteosarcoma, they only looked into follow-up. They had accuracy for bone lesions in PET-CT was 95%, very much better than CT or MRI alone. For Ewing sarcoma, also the case, but MRI was close. So osteosarcoma PET-CT is better than for Ewing sarcoma, and you can see that the uptake of FTG is relatively variable in Ewing sarcoma. Some of them really can have quite low uptake. So. And the PET-CT was very much better during follow-up versus initial. The diagnostic benefit they've seen in 9 from 20 patients in osteosarcoma and in 21 from 44 Ewing sarcoma patients. So clearly, PET-CT contributes at staging and follow-up. As I told you, it's very difficult really because it's relatively rare. It's young adolescents or young adults mostly having Ewing sarcomas, so imaging and frequent imaging is an issue. We have in Münster a relatively large group of patients that we have followed on. So this is a study from Münster where we looked into 80 patients in follow-up over several years. And we wanted to look at the value of imaging during follow-up. So this one is the scheduled follow-up meeting, but of course, as you know, it's not always in the same day, same week, and it's not really a prospective study. So that means it is not really that you have all the imaging things on the same day as you would do with the study, interpreted independently and then compared, but basically they wanted to have the best coverage and the best trade-off in finding tumor recurrence early, but not having overly high radiation exposure. So normally whole body MRI, for example, would not be done at the same day or same time as PET-CT. So it's a retrospective study, but still gives you some indication what the different modalities, inclusive of PET-CTs, are worth. That are in this group of 80 patients were the recurrence characteristics, and for us important was were the tumor recurrence first diagnosed by this scheduled imaging, or was it first diagnosed by symptoms? And if you look at local relapse, it was 50-50, so 2 out of 4 was detected first by relapse before advent of symptoms. In lung, it is very high. Almost all, 90% of the relapsing patients were discovered in imaging. So lung tumors are good to image by CT because they are detectable when they're only a few millimeters large, but they don't. No symptoms occur at that time. But if you look at bone metastases, then the tumor image, the imaging, scheduled imaging, is very important. It detected in more than half of the patients detected relapse before the advent of symptoms. So combined, in 67% imaging was able to see a tumor recurrence before symptoms. So that's that. And if you look then more closely, what imaging modality was responsible for early detection, and then that was the total number. It was an MD student. She really looked into the data from nearly 2,000 studies in these patients and really see what was going on. And you could see that even though the PET-CT studies were relatively low in number, 138, they depicted 8 of the recurrences. That means in almost every 20th scan, it detected the recurrence. And for X-ray, for example, that's very unfavorable. So only very rarely it detected a recurrence, even though there were a lot of scans. MRI was not whole body, but localized scan that detected 0. X-ray CT was better. But PET-CT was really in this group led to a very high number of detected tumor recurrences. Now going to whole body PET MRI, whole body MRI. Whole body MRI gives you also worth versus bone scanning, but of course the combination with FDG PET, it's probable that gives you an advantage if you combine PET-CT with PET MRI, but then you have to look into the lung tumors, so you might have to add low-dose CT of the thorax, but this is still open for the future. So whole body MRI is of value. How that it really translates into advantage in combination with PET-CT is open. Very fast examples of whole body imaging with PET MRI. So that is a patient with a lot of recurrences. It's the first manifestation of Ewing sarcoma in the thorax, and that tells you that MRI is very good in looking what is soft tissue component and what's going on there. So soft tissue extension. This is a different case. It's a 13-year-old boy who was diagnosed at age 3 and had multiple recurrences of tumor that were treated again, staging for new tumor manifestations. As you can see here, he had a new tumor manifestations with hardly any FDG uptake, as you can encounter for Ewing sarcoma, and here really PET MRI made all the difference. Okay, conclusion. So PET MRI is much slower to grab market share than PET-CT was in the beginning. That is what everybody, I think, is seeing. PET MRI for imaging of primary and secondary bone tumors has potential. We are still missing the very big trials to really see whether that also the higher diagnostic performance translates into a survival benefit, for example. That requires good protocols, as I told before. Scientific data is so far limited. And I think for me, it still remains to be seen whether PET MRI will be routinely chosen over PET CT plus MRI separately for bone tumors in the future. But of course, PET MRI requires multidisciplinary effort to unlock its full potential, and at least, it's a very, very rewarding and very interesting, offers very interesting research opportunities. So, thank you for your attention.
Merci beaucoup. C'était un défi, un challenge de traiter à la fois les tumeurs primitives qui sont très hétérogènes et les métastases. Et c'était aussi un challenge parce qu'il y a très peu de données, comme tu l'as dit, actuellement, très peu de publications. Donc on peut effectivement croiser les résultats individuels sur la modalité IRM corps entier et ceux sur la modalité TEP-FDG, faute de mieux. En attendant les essais multicentriques. Avez-vous des questions à poser aux pour les deux dernières interventions, c'est-à-dire l'équipe d'Henri Mondor sur l'optimisation du parcours de soins et la présentation du professeur Lars Stegger sur les indications oncologiques, atropisme osseux, primitif ou secondaire? Juste par rapport à l'éditorial qui vient d'être publié dans le Journal of Nuclear Medicine, l'éditorial qui est sous presse de septembre, de l'équipe de Abbas Alavi qui dit au XXIe siècle, le but de l'imagerie doit être de dépister les métastases médulaires et pas la métastase osseuse. Mais en fait, à nouveau, c'est une misconception parce que la moelle osseuse, c'est pas comme de l'eau dans un aquarium, mais c'est dans un réseau de septa de l'os trabéculaire, et il se trouve que les métastases qui vont devenir cliniquement significatifs, c'est-à-dire les clones qui vont proliférer, ont besoin, ce qui a été dit par tous les orateurs, d'oxygène, de nutriments pour survivre, et pour cela, ils détournent les mini-usines qui sont théoriquement destinées à la différenciation des cellules souches hématopoïétiques et qui sont logées le long des travées osseux. Donc ce qui veut dire qu'en scintigraphie osseuse conventionnelle, comme en fluoride, comme en PET-OFNA, effectivement c'est une imagerie réactionnelle à cause de la localisation des développements des clones. Bien sûr, il existe toujours des exceptions et il existera toujours des faux négatifs si, par hasard, mais contre toutes les probabilités, les métastases osseuses, les métastases médulaires pures par exemple de tumeurs extrêmement agressives vont se développer sans jamais toucher aucun septa. Donc avec la réserve bien sûr qu'on va sous-estimer cette invasion métastatique. Simplement par rapport à l'édito d'Alavi qui est sous presse pour le GNM. Est-ce que vous avez d'autres questions sur Lewing versus ostéosarcome? On sait bien que, comme tu l'as dit, l'incidence est rare, c'est 2 par million. C'est l'incidence de ces tumeurs primitives, donc c'est vrai que pour avoir des séries, c'est voilà. Bah écoutez, si vous avez faim, je pense que vous n'allez pas être déçus. Et je vous remercie infiniment d'avoir participé, animé cette soirée, conjointement aux orateurs que je remercie et que vous pouvez remercier à nouveau.